Taylor. I'm faculty in the College of Medicine in the Division of Infectious Disease, and I am a co-director of the Bridge, one of the co-directors of the Bridge program. And so today I'm going to give, because you guys are a new cohort, so you did not see this particular lecture. I'm working on it. Hopefully I'm going to get the kinks out here. But today we're going to talk about ageism in healthcare. I just want to make a little bit of a disclaimer that if I have to mute myself because a bunch of rowdy boys come into the room, this is just my situation. Okay, so ageism in healthcare. Oh my, I have to, so I can see. So this, oh crap, I'm so sorry. I'm just trying to be able to see what's on my screen. So basically these are the modules in group A. And I've highlighted that ageism is one of those modules that you, if you are taking this for a certificate, that you will receive. Oh, Christmas. These are our acknowledgements. Our program is funded by HRSA. And here's information about our funding mechanism. I have no conflicts of interest. And this is just a quick sort of list of some common acronyms that we might use. In this particular, actually, none of these acronyms are applicable for my lecture. Okay, our learning objectives. First, we're going to define ageism and the different types and also discuss the different types and forms. We're going to discuss ageist language in clinical encounters. We're going to discuss the impact on the delivery of quality care. Oh my goodness, something has happened here. And the most common ageist assumptions among healthcare providers. And then at the end, we're going to discuss a model to address ageism in clinical practice, or several models. Again, we want to remind you about our sort of overarching framework as an in terms of age-friendly healthcare, the 4 M's, what matters, medication, mentation, and mobility. I really actually feel that sort of the topic today talking about ageism will fall under what matters in terms of care preferences, but more in terms of how we are really being mindful of our words and our actions as we are helping our patients. So what is ageism? It can be a lot of things. And what I'd like to first do, and I'm not sure if the participants can are able to unmute each other if they have a comment. But what I'd like for us to do is briefly start off with what we know. How do you define ageism?
And anybody can unmute.
Anyone can jump in.
Sure. So all attendees, please feel free to unmute and speak up or put the answers in the chat.
Well, I can't really see the chat, but what I would ask is if you unmute yourself to ask a question, please remember to mute yourself again. So I'd really love to hear what are your start, you know, where's our knowledge right now? What do you guys know about ageism? How would you define it?
Hi, Dr. Taylor. It's Ayana.
Hi, how are you?
I'm good. How are you doing?
Excellent. So how would you define ageism, Ayana?
Isn't it like a form of discrimination based on like somebody's age?
Yeah, absolutely. Can you tell me anything else about it?
I don't really know the different types. That's about all I really know.
Okay, so it's absolutely discriminatory. Anyone else want to jump in? What else is ageism? So it's discrimination. What is this discrimination? Where is it coming from?
Hi, Dr. Taylor. This is
Hi.
Lily. So I'm guessing ageism is like in healthcare is like, or generally, if we think about the old people, we think, oh, memory loss is normal for old people because I'm getting older. So it's more like an example of ageism, or like, oh, you're older, okay, it's okay for you to be false, or it's okay for you not to able to take care of yourself, or we feel like all people are more stinky like that because of odor or smell. Is that
Right.
considered ageism?
So Lily, you're awesome. Lily gave us some really good examples. All right. And, this assumption that all old people smell, or I can't remember all of the good examples that Lily just gave us, but these are all assumptions or stereotypes that we are applying to all older adults. Do you think that there are different types of ageism?
Yes, absolutely. This is Clivia.
Mm-hmm.
Okay, you have some, it could be based on your gender, your religion, socioeconomic status, so on and so on.
So what Clivia is talking about is, I think, kind of the intersection with an age discrimination or bias and other aspects of a person's identity that are folded into it. So for example, homophobia, ageism and homophobia, or ageism and gender, or ageism and sort of racism, right?
Yes.
Okay, thank you.
You're welcome.
So I want you to think about the last point in terms of how ageism impacts interprofessional collaboration, because this is very important. When being part of a team, there are lots of different roles, and also within the team, there might be ageism. And I want you to think about that. We'll talk a little bit more. So basically, ageism is a bias. Okay, and here's the big simple, a bias is a prejudice in favor or against a thing, a person, place, or thing, a group, compared usually with another. This is the standard definition of a bias. But seldom people don't think about bias or ageism being in the head, being a cognitive sort of factor. So the bottom line is, I want us to think about the fact that, like, we all have a brain, we all have bias. And we know this because we know about the brain in terms of the amygdala being associated with emotional learning and fear and conditioning. And the hippocampus is where information and memories are processed. This is where these fears and biases develop, are through our lived experience, and they are located forever in our brains. We know that the frontal cortex is responsible for empathy and emotional responses, as well as rational thought. But that empathy, developing that empathy around feeling compassion for individuals who are challenged, maybe because of the aging process in terms of disability, in terms of cognition, etc. And the temporal lobe is, as we know, responsible for all of these integrations of sounds and words and meaning and memory. Memory is something I want us to come back to, okay, in terms of how particular negative memories stick to us like glue, while other memories just disappear, we can't hold on to them. So probably the most important form of bias is, or especially within medical training, is one that we like to focus on the most, which is implicit bias. And to be perfectly clear, ageism is a form of implicit bias. So implicit bias are often, just like Lily sort of said, you see a patient, immediately you go to this association. Older person, they must be smelly. So it's that instant association of a stereotype or an attitude. And honestly, they can be both favorable and unfavorable. That old people are so quiet and kind, you can totally take advantage of them, right? But the thing about implicit bias and most forms of bias is that they are often unconscious, and that people are really not aware that they hold these biases. And that's part of what we're going to do today. I really, just like we have a cultural humility, I want you to think about trying to figure out where's your bias around aging, because we all have them. And what we need to do is we need to uncover them so that we can, be able to address these. Okay. And what I'm asking you to do is I'm asking for you to look for your blind spots. Okay. They're seldom easily accessible by, introspection and sort of self-assessment. Often sort of this bias around aging, it operates unconsciously, but people see it in our behaviors and they hear it in the way that we speak. Okay. And so we need to be really cognizant about sort of when people call us on something, to be mindful. It's now we're aware. This I just wanted to share with you in terms of the brain's negativity bias. And this is a particular type of bias. And I was telling you that sort of there's this notion about a mental residue that basically, despite the fact that people can be committed to diversity and equity and inclusion, that sometimes they might still operate with this particular bias. So for example, despite like oodles and oodles of positive experiences, which slide off like this egg on this frying pan or Teflon pan, it slides right off. But one negative experience can stick to you like Velcro. And the truth is, we're exposed to stereotypes all the time, but that doesn't mean that we're going to endorse these stereotypes or these ageist, assumptions or comments. But the thing is that often within healthcare training, sometimes these false assumptions and stereotypes can be, integrated into clinical practice or medical or nursing education if they're not acknowledged for what they are and discouraged. So the thing is that you as trainees might be confronted with ageist language coming from residents, coming from faculty members. And so the thing is that sort of you need to be aware that that's not necessarily good role modeling, and that also to understand that not everyone is necessarily on this plate in terms of looking at their own biases. So ageism is defined as a systematic stereotyping and discrimination against people because of their age. This definition comes from Robert M. Butler, who was a very famous guy at NIA. I'm actually an NIA Butler Fellow, so I want to give props to him. In the healthcare community, there's assumption that, it's not there, or this sort of talk as if that it's not there. But the truth is, healthcare as a profession, as an industry, is not immune to the harmful effects of ageism, and that it's within us as providers. It's also within the mindset of older patients and even the structure of healthcare systems. So different types of ageisms. There's personal, institutional, intentional, and unintentional. So intentional and unintentional is basically where you are aware of your bias and you're just letting it all hang out. Whereas unintentional is going back to sort of the model of implicit bias. You're not aware. Institutional forms of ageism are sort of often those rules and practices that discriminate against individuals and groups because of their age. So for example, older nurses or physicians in terms of their ability to continue to work. They might gradually see sort of this institutional ageism in terms of when they must go, and of course also personal bias. But the roots of ageism in medicine is that often, and most often, these negative thoughts and attitudes towards older adults are shaped by exposure through your training process, often shaped by exposure to extremely frail and geriatric patients in the hospital. So if you've not been exposed to a lot of older adults, and let's say you didn't grow up in an intergenerational house, this might be your first real long exposure to older adults. And unfortunately, that exposure is with the sickest and the frailest versus sort of vibrant and active older adults in the community. You know, in addition to that, there's also your perception and your training of the fact that these older adults are just really complicated. They're just harder patients to manage. And, you know, to a certain extent, I think that this particular stereotype of older adults has really prevented people from recognizing how incredibly cool, for lack of better words, geriatric medicine is. That all of our patients are not complex. Older adults are really quite amazing. I'm going to see if this link actually works. Can you guys still see this?
Hey, how's it going? You can stand right there. That's her mark.
Yes, Dr. Dr. Taylor, and we also
What's
hear.
your first name and your age?
My real age?
My name is Paolo. I'm 25 years old.
My name is Daniela, and I'm 19.
24. 35.
31.
Okay, just to give you a little setup, this is about millennials showing us what old looks like. And this is part of a campaign called Disrupt Aging. Okay, so I'd like really showing this to our trainees because to a certain extent, whether you're millennial or Gen Z or Z, yeah, this is often, if you're not surrounded by people who are older, these are some of the assumptions that you may or may not hold.
I'm 33.
I'm 26 years old.
What age do you consider to be old?
Late 40s?
Maybe 50.
I feel like 30 is a new 20, so I'd say like 40 is old.
I'd probably say 50s.
I'd like you to show me how an old person would cross the street. Show me how an old person would send a text message. How might an old person do a push-up? What about jumping jacks? Okay, hang on. There's someone I want you to meet.
Hello, I'm Birch. I'm 66.
Hi, I'm Daphne, and I'm 68. I'm Dee, and I'm 55.
George Fassbinder, 75.
Wow. My name's Parvati. I'm 70.
Nice to meet you.
Nice to meet you. We're gonna give you about 2 minutes to teach each other something that you are good at.
I can teach you a jump that I do.
Okay, please.
Both of your legs go up, and your arm goes up, and your left arm goes like to the side. Ready?
Okay.
1, 2, 3. Lift. 1, 2, 3. And bring it to your heart. And bring it to your heart. Add the head in. Yeah.
You want to try to get your balance and raise up. Now, you bring your legs and your feet up. It's hard, right?
Yeah.
1, 2, 3, 5, 6, 7. So when you come out of a turn, either way, you go back to that basic.
Over. Now forward. Over. Yeah.
Square it like this, and give me a hook. Hook. Jab, cross. And then we'll go like this, all right?
1, 2, 3.
Now, what age might you consider to be old?
Probably 80 or 90. He could just do everything that I told him to do. An age that I would consider to be old now might be 100.
Do you remember what you said?
Yeah, I said in the 50s. I thought that would be all. But when I thought about it, like,
Wait a minute.
I'm sorry.
I can do it. It really changed my thinking of what old is. You've taught me something today. Clearly, there's no way she's old, you know?
Now I know from today, hey, I don't look at age.
At my age, I feel like I did when I was in my 20s.
There's so many things that I still want to do. There's so many things that I can do. As long as I'm growing and learning, then age doesn't matter.
When people start stopping, that's when they start getting old.
Thank you. Thank you so much.
Thank you.
Thanks, Daphne.
It was great meeting you.
How long have you been doing this? Is this a new skill?
40 years.
I love showing that interaction there at the end, and the fact that sort of that all of a sudden there's communication. People want to know a little bit more, because there's sometimes a tendency to with groups that we don't interact a lot with, we don't recognize that they're just like us. And so at the end, everyone was just like, wow, like, tell me more about you, etc. I really love that particular video, and that I hope that you guys will think about that in terms of the initial, or maybe for some of you, you have a lot of exposure to older adults, maybe through your grandparents or great-grandparents, but often you're overwhelmed with one particular side of seeing an older adult. And I need for you guys to keep in mind that that is just one side of the coin. Okay, apparently I have to, how do I get back? Okay, so ageism can be implicit. We know that. This is an example from an article that I read talking about how a surgeon mocked a medical student when she responded that she wanted to go into geriatrics. And he began mimicking an older adult complaining about constipation in a high-pitched voice or pitch whine. Like, how do you think you guys would feel about that? How would anyone feel?
Very unprofessional, very like stereotyping.
Right. But what would you do if, like, he's this attending surgeon and you're doing rotations? Would you feel like you couldn't say anything? I understand that's probably a difficult question to ask, but, you know, sometimes it is difficult to call people on their stuff. And the thing that I want to instill here is that we can only really address this ageism if people are able to call people on it. And I do realize that sometimes it's tricky because this might be a supervisor, but whenever that issue is not there, please do feel that you can sort of say, well, you know, that wasn't the best modeling in terms of ageism.
Hi, Tonya.
Yes?
Hi, this is Dr. Emmanuel. I'm one of the fellows.
Yes.
Hi, I just had, that is very interesting, because at one time, the hospital boss and one of the drivers, I was like, my specialty, I was like, I'm gonna go, like, what am I going into? Or what am I in right now? Something of that nature. And I told him that I was one of the geriatric fellows. He was like, geriatric? Why don't you choose something like neurosurgery or something like that? Why do you choose geriatric? So I was so I asked him, like, everybody has a calling, right? Then he was, and then I was like, everybody has a calling. Like, he is a bus driver. Like, if everybody was a doctor, who's going to drive the bus, you know? So by the time we finished talking, and then he kind of changed his perception on how he saw things.
Oh, that's really great. Your first name is Andre. That's really great. And I can imagine, and you can just answer simply, did it make you feel bad? Did it piss you off that someone would put down your choice?
It didn't actually piss me off, but I was more surprised than pissed.
Okay.
I was more surprised than pissed because, like, we know we have this stereotype, we have this thing that we have learned from the public, or some learning from the public, or from some friends or something like that, and people they don't know, and they carry it forward without even like thinking deep into it. Like, I could be making, there are jobs to make $1 million, but what makes me happy, you could be giving me $50,000 and I'm gonna be happy with that. So yeah, and that will give me more fulfillment in life than if I was doing something like, which is giving me $2 million and I'm not happy with it. So and also the calling, what God called you to do also matters. You want to change lives regardless of how much money you're getting. So
thank you so much. I really appreciate you sharing. And maybe we can come back to this. I want to get through these slides and have a little bit of time.
Sure.
So, healthcare trainees, so that should be two combined, typo, excuse me, are often exposed to persistent misconceptions that they're all demented, all frail, and somehow unsalvageable. This is a quote from an article in 2012. However, at the beginning of this pandemic, if many of you remember, there was a choice made at NYU in terms of not letting certain individuals with COVID go on respirators because they were old. And it sparked this real conversation about ageism and, whose life is more valuable. And so this particular quote, it's always a bigger save when you help a 35-year-old woman with kids, as opposed to an altered Aegis, 89-year-old with, some sort of stereotype about that particular older adult. This is a really lovely video. It's very short. Let's see.
I've been called many things.
Little old lady.
Grumpy old man. Weak.
But you didn't think that, right?
I'm the life of everybody.
I start trends.
I'm an activist.
I am in my prime.
I'm ageist.
This is my bingo Tuesday.
This is my senior moment in the city of Boston. I've been called many things.
Whoops.
Little old.
I love Irene. she's amazing. All right. The truth is that in addition to the ageism that we as providers might intentionally or unintentionally sort of share within our practice, it's also really important for you guys to understand that there's also ageism on the side of the older adult. There's such a thing as internalized ageism. It's basically when a person of a particular background, whatever, holds a negative view towards that background. There's internalized racism, there's internalized sexism, etc. And there is internalized ageism. So often older adults will basically, buy into these ageist assumptions. Health is for young. When you're old, you do the best you can. I'm having a senior moment. I remember my mother sort of saying that she, a long time ago, felt that that was an ageist quote. I'm not old, I'm just more mature, which, could possibly be turning this into, don't label me with these negative stuff. And go away.
Well, I'm just trying to find it.
Go away. Sorry, my kid just threw me off balance. So the problem with internalized ageism is that it can, to a certain extent, become a self-fulfilling prophecy. So that, the longer you think about these or hold these negative attitudes, it can then sort of impact your life and how you live. And more importantly, how they seek help. So if you believe that your pain, your fatigue, your depression, or anything else is a normal part of aging, you might be less likely to seek care. And, you know, with internalized aging, there's also this low expectation to engage in life and other preventative behaviors. So studies have found that people with internalized aging have, you know, less regular physical exams, might not continue to eat a balanced diet. They might sort of feel, well, you know, I don't really need that seatbelt, or I'm not going to exercise, or, you know, to think about changing their alcohol or tobacco use. Why is ageism in healthcare a growing concern? So I want to see, again, if like one or two people can chime in, just briefly, like, how does ageism impact the care and treatment we deliver? Unmute yourself, please. Nobody?
Oh, sorry. I think we have a tendency to put our own expectations and thoughts of what people may want or expect of themselves at certain ages. And so it can prevent us from asking certain questions or offering certain services or even considering certain diagnoses or treatments because of our own preconceived notions of what those patients may want for themselves.
Wow, Sarah, that's a brilliant answer. Like, seriously, you know, being aware that you have your own lens that you might be seeing sort of the aging process through, and recognize that that's not necessarily the views or the wishes of that particular person. That's really a great response. Anyone else? Okay, I'm gonna just quickly. One of the reasons that it is problematic to do, just as Sarah sort of mentioned, is that there's a real potential for undertreatment. Okay, so if we're applying sort of like age-based group characteristics to an individual, as opposed to looking at what's going on with that individual, we might miss things. Okay, we might not think that if someone is complaining about a sexual health issue or something else, that's really important because, well, they're older, so they're really not having sex. And that's the problem. The problem is that sort of often we can undertreat. So for example, this cartoon, you know, insomnia is very common, try not to lose sleep over it, being really dismissive. This is a real problem, and it's an intervenable problem. Pain is consistently undertreated among older adults. You know, in terms of underutilizing resources or denying medical treatment due to ageist assumptions, you know, often we've heard sort of these particular comments, you know, having more aches and pains is an acceptable part of life, or, oh, you know, the human body is like a car when it gets old and worn out. And these are things that folks will hold on to and believe that it's a part of the aging process and there's nothing that we can do. And, you know, there are things that we can do about aches and pains, and especially about depression. But, you know, the bottom line is this sort of dehumanizing of the older adult, making them just be sort of a number, as this cartoon sort of illustrates here, or just, you know, generalizing, you know, once you've seen one older adult, you've seen them all. In addition to a potential for under-treatment, there's also potential for over-treatment. And often these are harmful treatments that are based on misguided sort of like health recommendations for older people. And a lot of these are not, really don't have a lot of benefit. For example, like the universal prostate specific antigen screening for prostate cancer, or the overuse of particular tests and procedures that don't have evidence. And also I actually added number 3, that my grandmother, who was 101 when she passed, when she was one of her last times in the hospital, there was this immediate, like, they came in the middle of the night and disrupted my grandma. And of course she was like not completely lucid, because why would you wake her up? And they, like, all of a sudden it was like a code red, or not a code red, that's the wrong term. But basically the room became crowded with about 20 people thinking that, and I remember after that experience that we realized this was inconsistent with what my grandmother wanted. And we basically then decided on home hospice. In reference to sort of these unnecessary procedures, there is a guide to help you understand sort of what's necessary and unnecessary. So the American Board of Internal Medicine in 2012 launched this campaign called Choose Wisely. And basically they solicited information from like specialists to identify what tests were really important and which ones were not. So for example, like imaging for lower back pain, or annual electrocardiograms for low-risk patients, especially pap smears for women over 65. Ageist language. So the truth is, we see these forms of bias through our actions, but it's really through our language with ageism. And I want to see, can everyone like just unmute and give me an ageist word, like an ageist example of ageist language?
Sweetie, honey.
Senile, cranky, grumpy, slow. Pardon?
Pin in the
What?
butt. Pin in the butt.
Okay, excellent. And how do you think this language impacts care and treatment? What if you're in front of a patient and you call them frail? What do you think that's going to make that patient, how do you think that's going to make that patient feel?
I think they won't want to express themselves as they should.
Right. It might make them feel worse about where they are in their health current situation. Ageist language in clinical encounters. 1 out of 10 senior citizens believe that they have been looked down upon or are treated in a humiliating, shameful, or degrading way. 1 out of 10. And these are some of the words, senile, helpless, cranky. The truth is that there are some communication challenges with our older adults that can be due to sensory deficits, cognitive impairment, or the presence of a family member in the room. I hope everyone would understand that shouting or raising your voice is not very helpful. And that to ignore an older patient altogether and to speak only to the caregiver is patronizing. Failing to speak directly to an older patient can impact sort of, the information that you give. Not everyone is, completely aware of their history, and it's really important to also empower our older adults to play a role in their own care. There is this register, it's a linguistic register called Elder Speak. And if any of you guys are young parents, you might know of Motherese. Motherese is this way of talking to our babies where it's not our real voice, but it's like, oh, little coochie coo, or something to that extent. That's called Motherese. Elder Speak is something very similar. Elder Speak is where we modify the way we speak because we are engaging with an older adult. And so a lot of these older adults can hear that. They can hear how you are speaking differently. You're speaking slower or with exaggerated intonations or with an elevated pitch and volume, as I mentioned before. Or you might repeat things over and over again or use simple vocabulary or structure. For older adults, being talked to in this way is, again, demeaning and patronizing. It can result in lowering their self-esteem. It can exacerbate like underlying sort of mental health, like depression, reinforce their dependency on others, or, result in sort of increased social isolation. I'm not sure if you can see this this cartoon here, and you can see the person pointing, the fact that he has to, use a smiley face to express how he's feeling. Now, in addition, and I believe Clivia mentioned it before, that ageism can have a lot of different textures to it. And one of them is sexism. And so this is a really important video that I would like to share with you.
All right. How you doing?
Hi, good.
Have you ever done this before?
No. Exciting.
So tell me, how old are you?
19.
24. 29.
I'm 41. I'm going to be a mother for the first time.
42.
71. I'm 74.
I'm ready.
Okay, so we're just going to talk. You're going to show me stuff. Do I need my glasses?
I'm going to show you some slides, and I'd like you to fill in the blank and put the words "for her age" at the end of the sentence.
All right.
She has flawless skin for her age.
Beautiful for her age. She looks better than most 20-year-olds for her age.
She looks great.
She is beautiful.
Fierce for her age. In burlesque, I love it.
That might be a little bit inappropriate for her age.
Jane looks amazing for her age.
Her age? She's pretty hot. For her age. For her age. Her age. I'm going to show you some other slides now. So I'm just going to ask you to read the sentences that we provided for you. Okay. She dances well for a white girl.
That's not nice at all. It's just ridiculous.
She's ready for an immigrant?
No, that's so gross.
She's funny for an Asian. Oh my God, they're getting worse.
Well, this girl's half Asian, and me and her dad are pretty freaking funny, so she's gonna be funny. She's pretty for a thick girl. I hate that. You should not be defined by your size. Yeah, I hate that. She drives well for a woman.
You can't think like that. And then you bring up your kids like that. Then you have a society like that. We got another one? Is it gonna be worse? There we are.
She looks good for her age.
So I didn't expect this to fall apart.
They're all the same, narrow-minded and ignorant.
I'm guilty. I say for her age all the time. It's harder to look good in your late 40s. You can be hot at 23 and you just roll out of bed.
Sometimes I think it's good and sometimes I don't.
I didn't realize I was really insulting anybody because it's only because if someone says it to me, I think it's good.
It's not a compliment.
It's really like a backhanded compliment.
I think it is a bias. People are definitely labeled by their age.
I guess for her age is more commonly accepted. This is okay to say, which is like, why?
You look good is a lovely compliment, but to qualify it, you're saying, well, in comparison to the mainstream of beauty, you don't look good, but you look good for how old you are.
It's degrading.
I think everyone should understand this. I think people will be treated differently.
Say you look good, period. Don't add for her age.
No, I'm going to leave the for your age part off.
Unless you're asked these questions, I don't think you have the mind to start this conversation.
You know what? Everyone's going to get older.
Oh, okay. So I hope you enjoyed that and that you understand that sexism in particular, or ageist ageism directed towards women is so incredibly common. I mean, we live in a youth culture, and I feel like women more than men experience that. So I feel like I'm running out of a little bit of time. And so I want to quickly, I'm going to ask you guys this question. What is the most common ageist misconsumption among healthcare providers? That everyone is cognitively impaired, that older folks have lower capabilities, that they all have sedentary lives, that they don't do drugs, they never adhere to their medications, or that they don't have sex. Please unmute yourself to answer.
They don't have sex.
Who said that? Lily? Okay. Who else? Sorry if you're going to hear piano in the background. What else?
Cognitively impaired.
That they're all cognitively impaired. Thank you. You think that's the most?
Yeah, I agree with Louise.
Okay. All right. You know, it actually might be, but you know, what I want to talk to you about, and this is our big ageism alert here, is the fact that no one ever thinks of older adults as being sexual. This is a public service announcement that was done in Florida. I accidentally took off the citation to try to get folks to think about sexually transmitted infections and HIV.
Yeah, let's get this party started. Let's get your body rocking. Let's get your body moving. Party, party, yeah. Let's get it on. Party, party, yeah, yeah. Party, party, yeah.
Okay, so just quickly, what do you think that ad, why that ad did that? Does anyone want to take a guess? I mean, they could have gone about it a lot of different ways, right? So I'm just gonna cut to the chase. So it's very difficult to find images of older adults being sexual. I want to make a challenge for everybody here to think about one sort of popular culture image that really, really embraces sort of like sexuality among older adults, and you'll be hard to find them. And so I love this campaign because and I wanted to show it to you as our trainees, because you need to understand that as we get older, sex and sexuality never goes away as a part of our lives. And this is something that is really important because we realize that our young trainees might feel reluctant to have a conversation because this person looks like my grandmother or my grandfather. And the truth is, if you ever think that about sexual health with your patient, you're doing them a disservice. Okay? And I want to encourage you to remember that you're to take care of their entire health and well-being, not just like Sarah sort of said, in terms of making assumptions about where they are. Meet them where they are. So this is to get at sort of the ageism and sexism. This is a short video. Oh my God. No, nope, nope. Oh, Christmas. Oh, well, heck. Okay, so that one's not bad. This is another one. This is probably the only video I was ever able to find. hold on one second. So this is a Red Bull ad, and this couple getting down, and lots of Red Bull cans all over the floor. The truth is that many providers assume their patients, their older patients, are no longer sexually active. And the truth is that sexual activity does decline with age. However, that doesn't mean that people stop having sex. 53% of 65 to 74-year-olds and 26% of 75 to 80-year-olds are still having sex. Among those who are sexually active in their 70s and 80s, more than 50% had sex 2 or 3 times a month. So for the people who maintain sexuality, they're actually able to maintain frequency. Obviously, there are some issues with sexual function. There is in terms of women, in terms of menopause, and men in terms of andropause, more than 50% of men and women suffer from some type of sex-related problem. And only 38% of the men and 22% of the women talk to a provider about this. And that's a real problem. Physicians who are unaware of their older patients' sexual health and behaviors will miss what might be very, very important. Remember, I started off this conversation talking about what matters in this age-friendly healthcare environment. And if intimacy and being frisky with their partner is something that really matters, this is something that we need to help and work with them to do safely, so that they can maintain that part of what matters in their life. And I'm an HIV researcher, and I just also want to mention that sort of some of these sexual function issues result in lead to not safe sexual prevention practices, such as using a condom with erectile dysfunction. And models and strategies for ageism, or to combat ageism. So I discovered this wonderful model called the PEACE model, which is a positive education and aging and contact experience model. Remember, I held up a slide talking about the brain's negativity, holding on to bad experiences and, not being able to recall the good ones. Well, within this model, it's similar in the fact that sort of there's an effort to really increase the level of contact in different types of experiences with older adults. There's education, and we're part of that formula in terms of providing you informations and talking about negative and inaccurate sort of stereotypes and assumptions. But the other part is on you. It's on you to really make a concerted effort to think about having more than just the experience of older adults within our hospital, within this very specific clinical context. Okay. I was going to also just quickly talk to you about the diversity identity model. And this is for interpersonal and intra and interpersonal diversity. And basically, just like Sarah mentioned, for you to recognize and or for you to identify your blind spots, you're going to have to do some work. And that work is really about looking at your own lens. And your lens is your diversity identity profile. This is what makes you unique, just like your DNA. And that, how owning, just like Sarah mentioned, that we have to own the fact that we have this bias, and this bias can impact how we view the world around us and how we treat others, in particular, treat our patients. And then there's finally the emotional intelligence model, which again is this sort of, interpersonal. And I want to just make sure that in addition to thinking about what's going on in terms of your awareness and your own biases and trying to manage this, you never can, this model is incomplete if you're not able to also be aware in terms of what is happening with this particular patient and how to manage that relationship. And this is where empathy and kindness and not using elder speak and infantilizing our patients come from. Being aware that they might be not engaging with you and that you need to maybe try to speak to them in a different way. Recognize them, give their, let them speak, let them have a voice. And finally, I just want to conclude that there is the implicit association test sponsored out of Harvard. It's a wonderful test, and I would like for you guys, it's free. And what I would love for you to do is whenever you can, go and take the implicit association test for aging, for ageism. There, of course, is one for racism, for sexism, but there's also one for ageism. And it's a great place to start to try to figure out where you are in your process as you're moving to be more competent. Okay? And I want to thank you. And these are my references.